Okay, so welcome everybody. I'm glad to see you all. Today we will have a lesson on OCT. Dr. Khaled Amada will speak about OCT clinical data. So this will be a 15 to 20 minutes in-depth assessment of the clinical data that we have with this technology. We previously had another lesson on some technical characteristics and lesion addressing of by means of OCT, and today we will go a little bit deeper into the most important clinical data with this technology. We had some important novelties this year coming out with the presentation and publications of pivotal important clinical trials. So thank you, Khaled, for taking and investing your time in this lesson. I hope that it will be very interactive and interesting as usual. Thank you.
Thank you.
Please.
I will share my screen. Can you enable me to share my screen?
Yeah, of course. Please.
You see my screen now?
Yeah.
Okay. My name is Khaled Hamada. I'm a cardiology teaching assistant at Kafr Sheikh University, Egypt. Our talk today will be about the OCT clinical data. Our objectives today, OCT basic principles. I think we can skip this part because we had a previous talk about it.
But you can have a brief resample on this part also if you want.
Okay. Second, OCT assessment of coronary arteries. Third, clinical uses of intracoronary OCT and its clinical evidence. And finally, we have a conclusion. OCT basic principle. OCT is a modality of intravascular imaging that uses infrared light to produce high-resolution images of coronary arteries compared to IVUS, which use ultrasound waves. Compared to IVUS, also OCT offers a 10-fold higher resolution, about 15 micrometer axial resolution and 25 micrometer lateral resolution. The higher resolution of the OCT comes at the expense of limited tissue penetration depth, which is limited to 1 to 2.5 millimeters. OCT sees blood-rich core artifacts, so a blood-free medium is needed, which is done usually by continuous infusion of contrast during OCT pullback. OCT dates back to 1990 when Dr. David Huang first studied the use of OCT for retinal imaging during his PhD program at MIT. Since 1990, more than 5,000 articles about OCT were published. How does the OCT work? Near-infrared light is produced from the light source of the device and directed at the coronary artery through intracoronary catheter, and then the reflected light is measured. We measure the amplitude, the device measures the amplitude and the echo time delay of the reflected light, and they can generate cross-sectional images of the coronary artery. And with the aid of 3D reconstruction, we can have longitudinal images of the coronary artery also. OCT images are depicted in a false color scale. This is the OCT device. A is the console, which contains the light source and the computer and image display screen. Number B is the automated pullback device, which allows up to 20 millimeter per second pullback speed. And number C is the OCT imaging catheter, which is a short monorail catheter within a transparent sheath, and it rotates during pullback, introduced into the coronary artery over a regular PCI guide wire. The OCT images are shown in what's called a color map. We have two color maps, the sepia scale, which ranges from black, which gives a low OCT signal, like this, to brown, and the higher is the yellow, which represents a high OCT signal. The gray scale ranges from black, which is the low OCT signal, to white, which is a high OCT signal. The OCT signal depends on two physical properties, which is the backscatter. Backscatter is a reflection of light waves of the tissue back to the OCT catheter. If the tissue has a high backscatter, it gives a signal-rich bright region. If the tissue has a low backscatter, it gives signal poor, which represented in dark regions. Second is attenuation. Attenuation is the reduction of light wave intensity as they pass through the tissue due to either absorption or a backscatter. Tissue with high attenuation, light cannot penetrate very deep like thrombi, so we cannot see behind. Tissue with low attenuation, light can pass through and allow visualization of deeper tissue like fibrous tissue. Calcium and fat have intermediate levels of penetration. We will see further images. This is an example of attenuation. A with high attenuation like lipid, so we cannot see the full thickness here. B, low attenuation like this fibrous cap atheroma. OCT assessment of the normal coronary artery. The normal coronary artery consists of three layers, the intima and the media and adventitia. Usually with OCT images, we look first at the media, which consists of smooth muscle cells and elastic fibers, so it gives homogeneous low intensity signal. This is the media, bounded externally by the red dot line, which is the external elastic lamina, and the outer layer is the adventitia, and internally by the internal elastic lamina is shown in green dotted line, and the inner layer is this intima. Usually the normal intima is beyond the OCT resolution. However, it can seen if it is thickened. If the intima is thickened, it gives high intensity bright signal like this. This is also the three layers of the coronary shown in both the sepia and grayscales. This is OCT qualitative description of atherosclerosis. This picture shows the fibrous cap, which is rich, fibrous plaque, which is rich in collagen and smooth muscle. It has a backscatter and low attenuation. The high backscatter gives a bright signal, and the low attenuation, so we can see what is behind the plaque. Second, the lipid-rich or necrotic core. It has a signal poor intensity, usually homogeneous. This, we have a lipid plaque from 5 to 12 o'clock. It has diffuse border, so we cannot see the full extent. It has high attenuation. We cannot assess its full thickness. The calcification is shown as dark signal. More areas, usually it has a granular consistency like this with a sharp, well-demarcated borders. The calcium has a low attenuation, so we can assess the full calcium thickness. This is the advantage of OCT compared to IVUS. The red thrombus here is a luminal mass with a high backscatter, so it is bright, and also higher attenuation, so we cannot see behind. The white thrombus is a luminal mass also, but with less backscatter, so it gives less bright signal, with low attenuation, so we can see behind more clearly. This is a summary of OCT qualitative description of plaque morphology. First, if we can see the external elastic lamina adventitia well, so it is a fibrous plaque mostly. If we cannot see, then the second question is the signal change in the lumen or in the wall. If it is in the lumen, means that it is a mass or thrombus. If it has high attenuation, it is a red thrombus. Low attenuation is a white thrombus. If the signal change occurs in the wall with high attenuation, so it is a lipid plaque. With low attenuation, so it's mostly like calcium. Second, clinical uses of intracoronary OCT. We use OCT for diagnosis of vulnerable plaques. Second, assessment of calcification. Third, for guidance of stent deployment and post-stent optimization. Fourth, for assessment of stent failure mechanism and guidance of treatment. And last, for MINOC. First, diagnosis of vulnerable plaques. Vulnerable plaques are characterized by thin cap and high lipid content. The OCT was compared to histopathology in a study compared vacuum et in 2009. The OCT can detect thin cap.
Sorry to interrupt, Khaled. There is actually, I would say, an exception. We may discuss about this because try to think.
We have an next token.
No, exception on vulnerable plaques because here you say correctly that vulnerable plaques are usually characterized by thin cap and high lipid content. This is true, but there is an exception. try to think at another type of vulnerable plaque, which is not characterized by high lipid content.
Okay, the calcium nodule, I think.
Yeah, this is very,
Nodular
very
calcium.
correct. You said it right. The eruptive calcific nodule, we had one very interesting case during a live case I had in Indonesia 2 weeks ago. We were addressing a highly calcific LAD. We managed that, but we did the OCT and we observed by chance an eruptive calcific nodule in the left main. So correct. Please go ahead.
Thank you. I have a slide about the eruptive calcific nodule later.
All right, great.
So as we were saying, the OCT can detect the thin-capped fibroaceroma with a sensitivity of 90% and specificity of 79% compared to histopathology. This is the thin-capped fibroaceroma by histology and IVUS and OCT exam. As we mentioned before, the OCT has high resolution, so it can measure the thickness of the fibrous cap overlying the aceroma. Less than 65 micrometer is defined as thin cap. The clinical significance of lipid-rich plaque detected by OCT was studied in a 4-year follow-up study, which included 1,474 patients from Massachusetts General Hospital OCT registry. Non-culprit lipid-rich plaques was defined as lipid plaque that was not related to the index event and had a lipid arc of more than 1 quadrant assessed by OCT. They defined the MESIS as composite of cardiac death, acute myocardial infarction, and ischemia-driven revascularization. As we can see in this graph, lipid-rich plaques has higher MESIS than non-lipid-rich plaques. Also, they found that lipid-rich plaques patients showed longer lipid length, wider lipid arc, and smaller luminal size. Another study examined in vivo vulnerability grading system of plaques causing acute coronary syndromes. They concluded that the presence of 3 OCT features of vulnerability, minimal luminal area less than 4 square millimeter, and the fibrous cap thickness less than 75 micrometers, and superficial macrophages identifies culprit ACS lesions with a very high odds ratio. They were criticized because the number of patients was small. It was 63 patients. However, the same criteria with some modification of the minimal luminal area less than 3.5 square millimeter and the addition of lipid arc circumferential extension more than 180 degrees were validated in the climate registry that included higher number of patients, that was 1,003 patients. Also, the combined OCT FFR signals, they combine both the OCT and FFR in the patients. After FFR assessment and revascularization of FFR positive lesions, patients with FFR negative lesions, they called them target lesions, were classified into 2 groups based on the presence or absence of thin-capped fibroaceroma lesions. The primary endpoints compared the 2 groups for a composite of cardiac mortality, target vessel myocardial infarction, clinically driven target lesion revascularization, or unstable angina requiring revascularization requiring hospitalization at 18 months. As we can see here, the cumulative incidence of MESIS was higher in patients with thin-capped fibroaceroma. So they concluded in diabetic patients, thin-capped fibroaceroma represents 25% of FFR negative lesions, and OCT detected thin-capped fibroaceroma is associated with a 5-fold higher rate of adverse events despite the absence of ischemia. Thin-capped fibroaceroma in this study was defined as any lesion predominantly lipid-rich plaque in the thinnest part, less than 65 micrometer, and lipid arc more than 90 degree on OCT assessment. Also, OCT studies shows increase in fibrous cap thickness in response to treatment with lipid lowering drugs, statin and ezetimibe, what's called as plaque stabilization. First, this study examined the effect of statin therapy on coronary fibrous cap thickness. They included acute myocardial infarction patients who were divided into two groups. Group 1 statin treatment, number was 23. Control group is the second group. Serial OCT analysis were performed at baseline and 9 months follow-up. As you can see here, the fibrous cap thickness increased in the statin treatment group more than the control group, and it was statistically significant. Another study examined the impact of fluvastatin plus ezetimibe against fluvastatin alone on the thickness of fibrous cap. They included 63 patients with angina intermediate lesions. The change in fibrous cap thickness was significantly greater in the ezetimibe plus fluvastatin group, shown here in red bars, versus ezetimibe group alone, fluvastatin alone, sorry. Second, the assessment of calcification. As we mentioned before, the OCT can assess the full calcium thickness. We have here what is called a deep calcium layer, and we have here superficial calcium, like this. And we have here the eruptive calcific nodules, as Dr. Cortese mentioned. It is like a calcium sheath protruding into the lumen and breaks the fibrous cap. Sometimes it has also a thrombus over it.
No, gruszeczka. Dobra gruszka.
Sorry.
I think it's Sylvia is dealing with the baby.
Okay. This is OCT-based calcium score, which includes 3 parameters. First, the maximum calcium angle less than or more than 180. Second is the maximum calcium thickness less than or more than 0.5 millimeter. And the third is calcium length less than or more than 5 millimeters. Lesions with a score of 4, which is a maximum score, had poor stent expansion. So they conclude that OCT may help with the use of dedicated calcium modification or debulking device before stent implantation, and they suggested that a deep calcification, which is somewhat benign, or a score of less equal or less than 2, may suggest the adoption of a non-compliant balloon, scoring or cutting balloons, and a score of 3 or more favors a different, more aggressive approach with orbital or rotational atherectomy or lithotripsy. The third one is guidance of stent deployments. There are many trials about stent deployment with OCT. We will talk about the Illumin 1 trial, which was an observational study published in 2015. Then the Illumin 3, which was a randomized controlled trial published in 2016. And then the late-breaking trials, Illumin 4, Octavius, October, and a network meta-analysis, which was shown in the ACC 2023 Congress. The Illumin 2 was just a post-hoc analysis of the 2 prospective studies, Illumin 1 and ADAPT DES. OCT and IVUS guidance resulted in a comparable degree of stent expansion. This is the Illumin 1 trial. They included 418 patients with 467 stenosis. They underwent pre- and post-interventional OCT and FFR. Based on the pre-OCT, the operator changed their decision about the procedure in 50% of patients, which represent 57% of all stenosis, either by selecting of different stent lengths, which was shorter in 25 and longer in 43%. Based on post-intervention OCT, further stent optimization was done in 25% of patients, and further stent post-dilatation was done in 81%, or placement of new stents in 12%. MACE incidence at 30 days was low, with death occurring in 0.25%, myocardial infarction in 7.7%, and repeat PCI in 1.7%, and stent thrombosis in 0.25%. The Illumin 3 trial was a randomized controlled trial that compared OCT to IVUS to angio-guided BCI. They included 450 patients with non-complex lesions. So they excluded patients with left main or right coronary artery stenosis, bypass graft stenosis, CTOs, and the plan to stent bifurcation and in-stent stenosis. Results: greater stent expansion was in OCT versus IVUS group. The minimal stent area with OCT guidance was non-inferior to IVUS guidance. The OCT decreased the uncorrected dissection and malposition than angio and IVUS guidance. At 12 months follow-up, there was no significant difference in target lesion failure and misses in OCT versus angio versus IVUS groups. The Illumin-3 trial faced some criticism because it was not statistically powered to detect the impact of strategies for BCI guidance of rates of clinical outcomes like target lesion failure or misses. The Illumin-3 design excluded, as we mentioned, the complex coronary artery regions, which may benefit more from the intravascular imaging, more OCT. The Illumin-4 trials included higher number of patients, 20,487 patients, randomized either to OCT or angio-guided BCI. Patients included were either high-risk patients defined as patients taking diabetes medication or having high-risk lesions like acute MI, bifurcation, CTO, and in-stent stenosis, and also severely calcified lesions. The primary endpoint imaging of minimal stent area after BCI, clinical for 2 years follow-up of target vessel failure, which was a composite of death from cardiac causes, target vessel myocardial infarction, or ischemia-driven target vessel revascularization. Results: OCT guidance resulted in improved procedural success as increased stent expansion and less major dissection and major tissue protrusion and treated focal reference segment disease and procedure-related thrombosis. However, OCT guidance failed to improve 2 years clinical outcome, except for probable or definite stent thrombosis, as we can show here.
Yeah. So
Okay.
I would like to have your and anybody else comment on the results of Illumin-4 trial.
I read some criticism about the Illumin-4 trial, which I'm showing you in this slide, because they recommended further stenting at edges only if minimal stent area was than 4.5 millimeter, which is very liberal. They could use a less aggressive approach like post dilatation with less sizes balloon. Also, they recommended the stenting of any edge dissection which is larger than 60 degree and more than 3 millimeter in length, not mandatory extending to the media. So they also had a higher stent number.
Yeah, but which is your interpretation of the results of this study?
I think
Silvia,
yeah.
Wojtek, Alessandra, Sarah, and Krupal, do you have any other comments on this study? Because there was a huge expectations from this study, and despite, as expected, the stent expansion is better, and also procedural-related complications are lower with the OCT. Anybody was expecting an improvement after 2 years in the clinical outcome, but this did not happen. So how do you interpret this information?
The clinical outcome was low in all groups. So I think the low event rate couldn't differentiate between the improved outcome with OCT versus angio guidance.
So one interpretation could be that in this population, this is a sort of all-comer study which aimed to see if there is a role of OCT in an all-comer population, because, you know, this is not a very selected population. It's not mandatory to use intravascular imaging in this setting, whereas in some selected cohorts of patients, yes, because other studies, on the other hand, showed an improved outcome with OCT for example, for the management of left main, distal left main. I don't know if you will go through this data also as compared to angiographic guidance. So this can be an interpretation of the study. But okay, let's go ahead.
Thank you. The second trial also published in C Congress 2023, which was the OCTIVUS trial, compared OCT versus IVUS guided BCI, included 2008 patients. 73.5 patients had complex BCI. The primary endpoint was non-inferiority of OCT versus IVUS. Target vessel failure, which is a composite of deaths from cardiac causes, target vessel-related myocardial infarction, or ischemia-driven target vessel revascularization at 1 year. The main results that target vessel failure in OCT group was non-inferior to IVUS. Also, the OCT results in fewer major procedural complications and reduced the procedural time, and there was no difference in contrast-related risk factors between OCT and IVUS. The third trial was the October trial, which included 1,201 patients with bifurcation coronary lesions randomized either to OCT or angio-guided BCI. Primary endpoints were MACEs after 2 years. The main results that MACE after 2 years was lower in patients with OCT guidance versus angiographic guidance. And cardiac death, target lesion myocardial infarction, and the target lesion revascularization was also lower in OCT guidance versus angiographic guidance.
Yeah.
Okay. The fourth was a network meta-analysis, which
you can drink some water if you want, because I can see that you are having some issues.
Thank you.
Too much. You can take a rest.
Okay, thank you.
You can start again when you want.
I think we can continue.
All right, please.
Thank you. The network meta-analysis included 2,428 patients from 20 randomized trials of intravascular imaging guided BCI compared with angiography guided BCI. They included the recent Illumin 4 and October trials. The main results of this study, of this meta-analysis, that intravascular imaging resulted in reduction of primary composite outcome of target lesion failure by 31%, cardiac death by 46%, target vessel myocardial infarction by 20%, target lesion revascularization by 29%, and stent thrombosis by 52%. And the results were similar comparing IVUS to OCT. Studies about guidance of stent deployment for pre-stent sizing. Pre-stent sizing, we have two parameters or two choices, either sizing of the stent according to the lumen, as we can show here in the red dotted circle, or sizing according to the external elastic layer diameter, as we can show here in the white arrows. The opinion trial used the mean luminal diameter with upsizing to the nearest 0.25 millimeter. However, the Illumin 3 trial used the distal external elastic lamina derived from the mean of two orthogonal measurements, or only one measurement of the external lamina is visible only to 180 degrees, and they downsized to the nearest 0.25 millimeter. About the stent length or the landing zone, the proximal and distal references segment should have less than 50% plaque burden. It may be difficult to see the external elastic membrane and plaque burden by OCT if it has a high lipid content. The Illumin 3 trial requires healthy landing zone with avoidance of lipid pools and thin-capped fibroaceroma. The October trial used the reference area with luminal stenosis of less than 30% of the best looking lumen. About the post-stent expansion criteria, the CLI OBCI registry used the absolute minimum liminal area of 4.5 millimeters square millimeter as a threshold for discriminating a patient with MESES. The doctor's trial used absolute, which is more than 5.4 square millimeter, or relative, which was minimal luminal area more than 80% of average reference lumen area. The lumen 3 and the lumen 4 used absolute minimal stent area of more than 90% in both proximal and distal reference area, and the opinion trial used minimal stent area more than 90% of the average reference lumen. These are the targets for optimization criteria according to the European Association of PCI consensus on intravascular imaging. First, about the stent expansion, minimal stent expansion by OCT more than 4.5 millimeter squared, or minimal stent area more than 80% of the average reference lumen. And second, the section, it requires that it is less than 60 degree and limited to intima, not extending to the media, and less than 2 millimeter length. Also, the distal and proximal references with plaque burden less than 50%, malposition axial distance, this is axial distance, less than 0.4 millimeter and less than 1 millimeter in length. About stent failure, OCT with high-resolution images can detect the exact mechanisms of stent failure, including in-stent stenosis and in-stent thrombosis, and guide subsequent treatment. Sky Expert Consensus Statement published 2023 recommends imaging guided coronary stenting at the time of initial implantation to minimize the occurrence of stent failure. When stent failure occurs, imaging should be strongly considered to minimize the stent the subsequent approach. These are the Sky classification of the mechanism of stent restenosis according to the time. Early in stent restenosis, most to undersizing or underexpansion or stent fracture. Late in stent restenosis from 30 days to 1 year, mostly due to delayed healing and covered stents or intimal hyperplasia. Very late, more than 1 year, due to new atherosclerosis, intimal hyperplasia, and stent fracture. This image shows.
Okay, Khaled, I think that the time allocated is over because this presentation should last a maximum 20 minutes, 25.
Okay.
So if you can jump to the conclusions, or if you have some few slides that you want to underline, some images maybe, I don't know, or just the conclusion.
I have a few slides remaining. I think there's 5 or 6 slides just.
Okay, please go ahead.
Okay.
If I'm asking the other fellows to mute themselves, please.
Thank you.
Right.
This image shows a possible mechanism of in-stent restenosis. On coronary angiogram, we cannot differentiate between these mechanisms, and OCT can differentiate between stent under expansion like this. This is the stent, and this is the lumen, so the stent is grossly underexpanded. Second is the stent fracture, shown in 2 layers of stent on one side and no stent coverage on the other side. Third is the new intimal hyperplasia as this bright color. And this is the new atherosclerosis with a lipid-rich plaque. Second is stent thrombosis. These are the risk factors for stent thrombosis. You can skip it. This is a coronary angiogram showing stent thrombosis in LED, RCA, and RCA. The OCT can differentiate between the mechanism of stent thrombosis. This is stent under expansion. This is uncovered stents, and this is the new atherosclerosis. Last thing, OCT in Minoka. OCT with high resolution can help identify possible causes of Minoka. Two studies examine the role of OCT in Minoka. The first was by Gerbot et al. In 2020, second Reynolds in 2021. This is a study by Gerbot et al. It included 40 patients with Minoka. The OCT could identify the cause of Minoka in about 32 patients. The OCT could only identify as a sole mechanism in 9 patients, and OCT and CMR in 23 patients. The mechanisms were plaque rupture, plaque erosion, lone thrombus, SCAD, or eruptive calcified nodules. Another study examined the OCT role of Minoka in female patients. They concluded that the OCT could identify the cause of Minoka in about 67, which represents 46.2% of patients. So to conclude, intravascular imaging, IVUS, and OCT are equivalent and superior to angiography in guiding and optimizing most PCI procedure. They carry 5 features of optimal stent implantation, expansion, apposition, and further complication, as well as the mechanism of stent failure that are hard to know using coronary angiography alone. This favorable impact requires good patient selection, proper technique, correct imaging interpretation, and adequate operators' reaction to the findings. And thank you.
Okay, thank you, Khaled. It wasn't easy to summarize a lot of interesting information about OCT use in daily practice. This technology, as you concluded, also requires some good interpretation. In my experience, many centers just refer to the OCT on how a way to implant a stent, and so they just observe how the stent is implanted, if it's well apposed, if there is no dissection proximally or distally, and so on, which are truly important information, but considering OCT or IVUS only for this is a sort of underestimating the potentiality of this technology. I believe that also other areas and momentum of the angioplasty should benefit from OCT analysis, mostly before the decision of which treatment to use, which tools to use for lesion preparation, either for the use of stents or drug-coated balloons. So it is very important to understand how the plaque is characterized by OCT before the final treatment is achieved. And mostly now that drug-coated balloons are coming out as a very potent alternative to drug-eluting stents, I think that wasting, which is not a waste, but spending more time at the beginning of the angioplasty, actually in some selected cases with imaging, is of paramount importance. Yesterday, we did a very complex 3-vessel disease PCI. There was a huge calcification. Unfortunately, in that cath lab, I didn't have a possibility to use imaging. So in the end, after the LAD, after the circle, we had to stop in front of a huge calcification of the right coronary artery. I believe that OCT analysis would have helped in the decision of which tool to use for lesion preparation. And so probably we would have done the 3 vessels in the same setting instead of the necessity of postponing the angioplasty to another day. So this is just an example on how it is important to correctly manage and interpret the information that derive from OCT and IVUS in the planning of a complex PCI.
Unfortunately, OCT is not readily available in Egypt. Very low use in selected centers just.
Yeah, there is a military hospital there that have.
Yes, the military hospital have wide.
They have everything.
Everything.
They are really rich. But yeah, I know that OCT. I did a live case at the Cardiologists this year, and but we had to use IVUS. My IVUS is good. IVUS is good. It's a little bit different. Actually, if I have to admit, I prefer to use OCT, and I'm more experienced with OCT. But also IVUS is an important tool. I don't believe currently, this may sound a little bit strong, but I don't believe that we should use imaging in all of our cases now in 2023.
So how percent of patients do use regularly OCT?
OCT 30 and IVUS 10-15%. For example, in the CTO, IVUS is probably better if you have to puncture the cap in case of ambiguous cap, or if you do a reverse cart. There, OCT has no role, and so you have to use IVUS. But in a highly calcific lesion and for left main and a complex bifurcation, I think that OCT is preferable if you are able to interpret
And then
correctly
stent
the information.
restenosis, definitely.
ISR, of course, ISR. I think OCT is a little bit better than IVUS, because with ISR we have to understand the reason of the failure, because otherwise patient is going to come back. If you think that just a predilatation is enough after the use of DCB, you will have a recurrence of events in 15 to 20% of the cases. So yeah, I totally agree with you. I would like to see if people are still there listening to us. Excuse me?
I have another technical question about the ostial left main or OCT. I read some papers that they can use guide extension for the assessment of the ostium. Do you do that?
You can do it, but for the ostium, for example, unless it is highly calcific and unless you have a calcific nodule, I don't think that it is mandatory to use OCT or also IVUS. So if you have a focal stenosis of the ostium, and that I repeat is not highly calcific, you can go with a straight angioplasty. You can do it. You can use the guide liner. You put the guide liner at the mid of the vessel, at the mid of the left main, if it's not very short, and then you can see with the OCT across the guide liner itself. So you can do it. But again, I don't think it is mandatory to use OCT for ostium of the left main.
Thank you.
So guys, any comment on this very nice presentation?
Just a small question. Going back to the last trials, if you know, how did they assess ischemia-driven revascularization? I always have this doubt.
So we should look at the primary endpoint and the secondary endpoints description, and to see if in all of these trials only ischemia-driven TLR or TVR were assessed, or any type of TLR.
Yeah, because it can be different if you're going to look for something or just wait if a patient has an event. I don't know.
Okay, if you have an angiographic follow-up, this can be an issue, because there is often an over-interpretation of the meaning and the significance of potential restenosis. If you have just a clinical follow-up, it is not an issue, I think.
Yeah.
We should look a little bit deeper into Illumin 4 and October trials, which are the two most recent trials, to see how TLR and TVR were assessed. I don't know if Khaled, do you have the protocol with you now?
No, I don't. I don't have the protocol of the trial. No.
No, the protocol, just the publication.
Yes.
Let me see if I can find it easily. No, I cannot find it fast.
I will look for it later.
Yeah, no, this is a good point. I think that we can go a little bit deeper on this topic and discuss next time. Alessandra, this will be your task.
Fine.
Go deeper into this. It's important.
Fine.
Because one can hypothesize that in order to have more events, you can include all of the types of TLR, and so this point would lower, I think, the scientific value of a study a little bit.
Exactly.
Sylvia, any comment? How is the baby?
Hi, I'm sorry for the sounds background.
No problem.
I think thank you for your lecture. It was a really nice presentation of the state of the art about the OCT. So it's very valuable. So thank you very much.
Yeah, despite Khaled forgot to mention PROC2 study. Maybe next time. No, this is because I was the PI of this study.
I'm sorry, it was too many studies.
No problem, no problem. Dr. Krupal, any comments?
Yes, sir. Good evening. Yeah, it was a very nice presentation. But like some parts like I missed. But as far as IVUS is concerned, it is being like it's like quite promoted kind of. It is recommended, has come in guidelines also now, and it has shown reduction in the like clinical events. But with OCT, it's not happening in the same way as IVUS. Like why it is so?
So your question is, IVUS has shown in some studies a reduction in clinical events, but not OCT in the Lumion 4. Is this your question?
Yeah, I mean, it's my general question. Like, why my query is like, I have used OCT many times. It's very good. Like, it is very detailed and very clear images we get, and I feel it's better than IVUS. But still, IVUS is recommended in guidelines. I think an OCT is still not there. Like,
well, OCT came later actually, and Illumion 4 October trial and also other trials came out recently. You know that in Europe, the latest revascularization guidelines came out in 2018, so 5 years ago. And so I think that this technology will have an important part in the guideline next time. Despite I think that, as I said, we shouldn't use it. Excuse me? Who is Samsung? Who is speaking? Maybe he spoke.
Sorry, sir, it was my mistake. Amit this side, sir.
Okay, but who are you? You are Jagan or who? Who is Samsung?
Sir, Amit Munjal.
Ahmed. Oh, Ahmed, come on. We cannot see you. We just see Samsung. So, okay. So I think that also CT shouldn't be used in any case. That I say and I repeat this because some physicians are using imaging. I was discussing with a friend 2 weeks ago in the US. They are using imaging almost always. I don't think this is required, but again, 40 to 50% of the lesions of the PCIs, the current era PCI require an imaging adjuvants. Wojciech, we saw you, but we didn't hear your voice. What do you think? If you are still there, or you're doing another primary PCI? Anytime Wojciech is doing primary PCI.
Hello, I was driving.
Okay.
Hello, congratulations on the presentation. It's so interesting. We are all right. We are talking a lot about OCT imaging and about the studies comparing or assessing PCI treatment with drug-coating balloons and drug-eluting stents. And it is quite important, the point when we have a TICFA. And what's your opinion about treatment TICFA using the drug-coating balloons in compared to DES?
Khaled, the question was for you.
I think I didn't read studies about the impact of treating just thin capillary fibroadenoma, which is not functionally significant with OCT. However, there were other IVUS studies that compared the treatment or leaving this thin capillary fibroadenoma, and it showed no significant improvement.
Okay, This is an important topic, I think. ThinkUp fibroateroma assessment with OCT. First of all, unfortunately, there are no studies on the role of OCT before the use of DCB. This is the first thing. The second thing is that actually one study was presented on the role of OCT for the management of ThinkUp fibroateroma, but this was not clinically powered. It was a mechanistic study, a registry with a paclitaxel coated balloon. If I remember well, 40 patients, but the publication is not out yet. And it was presented at TCT by the group of the AMC in Amsterdam. So, and it shows that actually there is a potential healing effect of a paclitaxel coated balloon in a ThinkUp fibroateroma. But it is just, you know, a mechanistic study with no definite data.
Even if it was significant.
It was a registry, prospective registry of 40 patients. So they just checked again angio plus OCT after 6 months, probably, or 9, I don't remember. And they saw that there was an improvement in the thickness of the cap.
With the to balloon.
I don't remember what I have not seen the publication, just seen the presentation. I don't know if they use Cati balloon or not in the ThinkUp.
All right.
All right.
Thank you.
You're welcome. So if there are no more questions, our hour is almost finished. So I wish to thank you all, and mostly Khaled, for this very nice presentation. I'm sure that we will have other questions arising. Please share the presentation with Lisa so we can put it in our repository. If there are other questions next week, we can discuss about them. All right?
Thank you.
Okay. Right. Have a nice evening.
Bye.
Goodbye to everybody.
Thank you.
Ciao.
Bye. Bye-bye.